Hello, and welcome to our program on vaccine hesitancy and HPV. This is part of an ongoing program that we're doing through the Federation of Medical Women of Canada in terms of increasing our understanding about HPV and increasing our own expertise so that we will be comfortable teaching others and talking to our own patients. It's my total pleasure to introduce you to Dr. Marla Shapiro. She's our speaker for today. She needs no introduction. Dr. Shapiro is a professor at the University of Toronto in the Department of Family and Community Medicine. She has extra certification in public health and is one of Canada's most trusted speakers on medical issues as she speaks on CTV to the public on a weekly basis. So without further ado, it's my pleasure to introduce you to Dr. Shapiro, and she's going to give us an overview on vaccine hesitancy and HPV.
Thank you so much, and thank you so much for the invitation. I think the notion of vaccine hesitancy, particularly in the times that we are right now, is something that we are all talking about on a regular basis. And while my focus is on HPV, many of these concepts can be taken to talk about vaccines in general. The World Health Organization defines vaccine hesitancy as a delay in the acceptance or the refusal of a vaccine despite the availability of vaccination services. And this really is not a new problem for any of us, but it's a problem increasingly being recognized. It's complex, it's often context specific, it varies across time, places, and vaccines, and there are a number of factors that it includes, such as complacency, convenience, and confidence. And I think by understanding what vaccine hesitancy is all about, it will help us to engage our patients in a meaningful conversation to explain why we support vaccines, particularly in primary care, and it's one of our most powerful tools, the notion of vaccine preventable illness. We're more likely to see this with new vaccines rather than older, well-accepted vaccines, mass campaigns rather than with routine immunization. So I've mentioned to you the concept of the 3 C's: complacency, confidence, and convenience. And these will determine often the notion of vaccine hesitancy. And these are often general to any type of vaccine that you might experience hesitancy with. Confidence is defined as trust in the effectiveness of a vaccine and, of course, the safety of a vaccine. It also includes the system that delivers them, including the reliability and the competence of the health services and the healthcare professional, the motivations of the policymakers who decide on the needed vaccines. Complacency, on the other hand, is that perceived risks of a vaccine preventable disease are low and that vaccination is not deemed necessary to prevent this action. It's influenced by many factors, including other life and health responsibilities that may be seen to be more important at that given point in time. And this is very important because if you have a patient who says no to a vaccine at one moment in time, that doesn't mean that you should reintroduce it. Of course you should, because at a different point in time, they may be more open to taking the vaccine. Immunization program success may paradoxically result in complacency and ultimately hesitancy as individuals weigh risks of vaccines against risks of diseases that are no longer common. And that would often be true for things like measles, mumps, and rubella. But when it comes to HPV, I don't think this particularly applies. What about vaccine convenience? Well, that's access points to vaccination, willingness to pay for an unfunded vaccine, the culture of immunization, and now, of course, the impact of social media. So let's first look at factors contributing to vaccine hesitancy. Now, these are many intersecting areas, and we can speak about each of them. Firstly, there's often parent-specific factors when it comes to HPV: race, ethnicity and religion, educational level, income, their own knowledge about vaccines, past experiences with vaccines. And then there are vaccine-specific factors: the efficacy of a vaccine, the safety of the vaccine, and very importantly with HPV, the perceived disease susceptibility. This often is very low. External factors: the patient-provider relationship, what you say matters, how you say it matters, how strongly you endorse something matters. School immunization requirements, collective values and social norms, policies, and of course, the impact of the media. There are 5 types of vaccine hesitant parents: those who are uninformed, but really want to become informed. And your response as a healthcare provider is critical. You must listen to their concerns, educate them in easily understood terms, demonstrate the benefit of the vaccine, and provide a strong recommendation. So I think one of the most important aspects of providing vaccines is to never assume why a parent is vaccine hesitant, but to frankly ask them. The second one may be a misinformed but correctable hesitant parent. And again, asking them what they think is critical because it will drive you to a more pointed conversation to really talk about what their specific concerns are. That may mean data to debunk a myth, to acknowledge the risk and the limitation of a vaccine, to always be respectful, to validate their viewpoint, but then go ahead to correct it. A strong recommendation for the benefit of the vaccine. What about the well-read and the open-minded? So here often there are very specific concerns that this individual may have. So discussing each concern and referring to appropriate websites, which I'll give you some specific websites at the end of this discussion. And again, a strong endorsement for the vaccine. There are those who are convinced and content with their point of view. And again, I think acknowledging their concerns, but being strong and respectful in refuting them with scientific data is very important. Then there are the committed anti-vaxxers, and in this case, we're often unlikely to be able to convince them to go forward. But I think maintaining their trust, to refocus the conversation to the benefit of a vaccine, and to share information related to the risks of no vaccination. Patients often don't recognize that delaying a decision actually carries with it a decision, and that decision is not to vaccinate. And often we don't talk about the currency of what happens if you do not vaccinate and then you have the disease. Prevention is always better than treatment. In terms of communication, you need to be a champion. And we're going to look at some strategies as to the difference of statements in terms of what you say versus how you can actually say it and be a champion. Because communication can be nothing other than noise. And we like our communication to actually be pointed, clear, concise, and informative, recognizing that attitudes are important to look at before we can expect a behavioral change. So what are effective communication strategies? Firstly, you must set enough time aside. You must know the best communication means for that specific situation. Having reference materials ready or websites, and removing emotion from the conversation and removing knowledge barriers to be able to communicate the so-called elevator speech of clear, concise knowledge in an effective period of time. So there's a call to action for healthcare professionals. Educate yourself about HPV and HPV vaccines. What are some of the most critical pieces of information that you might know? For example, in Canada, there's no upper limit for age for both men and women in giving HPV vaccinations. And often there's a notion that I am too old to benefit from this vaccine, or I don't qualify for this vaccine. To recommend the HPV vaccine with strength and conviction based on the particular situation that you're looking at. Inform your staff so that everyone is delivering the same HPV messages, or they're able to say, come in to have this conversation. Communicate vaccination benefits clearly. Make vaccination procedures routine and focus on ways to reduce missed opportunities. For many of us who are on electronic medical records, we often have preventions that are listed. And I start every visit by quickly looking at my preventions to see, is every vaccine up to date? Being a champion means being an expert and a great communicator when addressing vaccine recommendations. Remember that your role as the healthcare professional is to partner, and part of that partnership means that you're an advocate, that you prioritize immunization access for your most vulnerable patients, and that you're affirmative in your recommendations. You support your affirmations with the fact that the guidelines you follow are written by experts, endorsed by national bodies. And you can identify resources for vaccines not offered in your office, websites that are .edu or .org that are not pharmaceutical based so that patients do not perceive that there is a pharmaceutical bias. So saying, do you want this vaccine or think about getting the vaccine is not a recommendation. Saying, you need to get this vaccine, and I really want you to get this vaccine, and now is a good time to get the vaccine. How can we make this happen? Is a strong endorsement and recommendation for a vaccine-motivated patient. Saying, do you want this vaccine implies that you're not endorsing the vaccine. Think about getting the vaccine implies we're not going to give it to you today. Think about it and maybe come back sometime in the future. This is not an endorsement or a champion of immunization. I think it's all about starting the discussion on vaccines and recognizing that we all need to own immunization. There are ideal times to include different changes in a patient's life. Personal. Now, that may mean someone who's coming in with an atypical PAP, or someone who needs to be referred for a colposcopy, or someone who's leaving a relationship, entering a new relationship. Overall health, moving and travel, to be able to say, before you leave my healthcare, let's make sure that everything is up to date. At the time of a periodic exam for some other chronic medical condition, to make sure that you've had this conversation. Immunization conversations can happen anytime throughout the year. And I think it's about partnering with your patient. But most importantly, in partnering, you must understand your patient's reason and the motives for their hesitancy so you can address it specifically. Understanding your patients is critical. Most of us assume that patients will not have a vaccine if it falls out of the funding of your provincial strategy. And often we think it's a question of cost, and we limit ourselves in making the discussion with our patient. When we ask patients about whether or not they've had a specific vaccine and the reasons why they haven't, many of the reasons include the following. My doctor never mentioned this vaccine, or I don't think I'm at risk for that disease. Now, that's easy to correct in specific situations. Or how and where can I get this vaccine? In fact, in many provinces, you can get a HPV vaccine by asking a pharmacist. Or my friend discouraged me from receiving this vaccine. And that too becomes an easy conversation to talk about where the expertise is and why it is that we are not discouraging them. A question often comes up: if it's important for my health, why is it not covered? And vaccine strategies are covered at certain points in time, but it doesn't necessarily mean that it's not important. And the CMPA reminds us that once a vaccine is considered standard of care, as is the HPV vaccine, we are obligated to inform our patients of the presence of the vaccine. Will I need to miss work because of this vaccine? That addresses concerns of accessibility. Or I had a significant pain the last time I received a vaccine. When I do give the vaccine, I often say that yes, you will have discomfort in your arm, and that's to be expected, but it will be short-term, usually a couple of days, and it's unlikely to impede you from doing your normal activities. And then, of course, does my religion support this vaccination? So does a vaccine not covered by public health mean it's not important? Well, the cost effectiveness of a publicly funded adult immunization program addresses almost exclusively cost savings in hospitalization and deaths on an individual basis, which is what we do as champions of immunization. The vaccine decision should engage the patient with these considerations: health factors including pregnancy, the hazard ratio with comorbidities, occupational risks and consequences of disease. For example, I have a veterinarian who actually is exposed to HPV, wasn't willing to get the vaccine, but because I brought it up, did her own research and recognized that in fact, she can get HPV from animals. Loss of productivity because of not getting the vaccine and then becoming ill with the underlying vaccine preventable disease. Potential loss of daily living capacities, the protection of others, And often when we see a woman in our practice with an atypical PAP where we may bring up and endorse HPV, we often don't think about talking about their partners and how their partner may benefit from the vaccine as well. And of course, for travel-related vaccines, that's a specific question. It's also important to evaluate your patient's predisposition to receive a vaccine because that will help us with the adherence to the recommendation. So ask open-ended questions. In other words, what do you know about this vaccine, the potential benefits, or what do you think about the risks? Which health benefit could this vaccine bring in your situation? And in your opinion, what could you do to prevent this disease and its complications? And often correcting women that even practicing safe sex, and men as well, will not necessarily prevent HPV. It will not prevent all STIs, although it's an effective strategy, it's not guaranteed. And why do you believe I recommend this vaccination to you? And when I'm recommending it for the third and fourth time, why is it that you think I keep recommending this vaccination to you? And I tell them it's because I know that it can offer you a health protection and a health benefit, and I keep recommending it to you in the hope that you will uptake the vaccine. Communicating the need for a vaccine. So I've just taken a look at your chart, and there's some vaccines that you haven't had, and I really do believe you need this vaccine today. Is it possible that you've received a vaccine in any other clinic since your last visit, particularly important for university students who may have received an HPV vaccine in their university setting? If not, let me start with why I think this vaccine is important, not only to preserve your health, but to prevent illness and maintain the health status that you presently enjoy. A vaccine can be a gift of health. And I think that the notion of a vaccine preventing an illness and what the currency of that illness will be, not to say that the currency of the actual cost isn't important, but these are one-time costs in individuals under the age of 15 who haven't gotten it at school. It's a two-time cost, but for individuals who are receiving the vaccine, even when it's 3 vaccines, these are set finite costs that will have ongoing benefit as you go forward in life. So it's important to positively frame the conversation. You, as the provider, will often need to initiate the vaccine recommendation. We know, for example, that a strong endorsement of a flu vaccine is what will get a patient to take the flu vaccine. If you endorse a pneumonia vaccine, you'll get over a 96% uptake. But if you don't, less than 7% of patients will come in asking if they should get a pneumonia vaccine. So there's the notion of presumptive and participatory. Now, participatory is what I'm hoping to achieve with the parent. To get the parent to respond to the initiation, there are those who will accept most of the time, and there will be some who will resist. But it's important for us to recognize that if they resist, to have the conversation as to why it is that they're resisting and what we might be able to do to further frame the conversation to encourage uptake of the vaccine. So presumptive is, it's time for Johnny to get vaccinated. In that case, 74% are likely to accept the vaccine and 26% will resist. But if you say something like, well, should Johnny get the vaccine at this visit, 4% will only accept, whereas most will resist. There's a difference between that phraseology. One is strongly presumptive that the patient is going to get the vaccine. And if you only take the participatory response, meaning asking them if they should get the vaccine at this visit without endorsing the vaccine, you're likely to find them to resist. So we'd like to take the participatory framework and move it over to a presumptive framework to really endorse a vaccine strategy and get the patient to understand why you are doing this. Does what you say matter? Well, it does, because if you strongly endorse it, you will find that often the child will receive the vaccine and some will not. There'll be those who are still deciding, but the endorsement of what you say typically matters. Here's that notion of presumptive communication in action. So presumptive communication means that you are presuming that the vaccine will occur during the office visit. You're coming from that standpoint. So you're talking about vaccination as the healthy default. You're focusing on the disease rather than the vaccine. because it's important to understand what it is we're trying to prevent. And we're not trying to correct misinformation necessarily as much as we are trying to focus on the disease to understand why we want to prevent this disease. Instead of saying, would you like to get your HPV shot today, which is a participatory approach, the presumptive approach would say, it's time to get your HPV vaccine. Instead of saying, I think the HPV vaccines are good, so you should get it, perhaps being more presumptive in terms of, I vaccinated my son and my daughter, and you should vaccinate yours too. Don't forget to get your HPV shot is not as strong as saying, if you do not get your vaccine here, let's make sure you get one at your local pharmacy. In other words, providing a strategy for where else you can get it. And I always follow it up with, if you do get the vaccine, please let me know so that we can have this recorded. And if not, we will have this conversation again. So what are the key steps in communicating with patients about immunization? Firstly, assess. Assess the vaccination status of all your patients in every clinical encounter. Has this patient had the HPV vaccine? And there are some patients that I am seeing in their 30s or 40s who have previous histories at atypical PAP where we may not have had the conversation because at the time when they were first diagnosed, the vaccine was given, let's say, to individuals up till the age of 26. The indication has changed with no upper age limit. And I find myself saying to patients, you previously had an abnormal PAP. We never discussed the use of the HPV vaccines. And we know that there is a never too late approach, meaning that you can have benefit from having this vaccine, even at this stage. Strongly recommend the vaccine that a patient needs and administer the needed vaccines or refer to a provider who can vaccinate. Right now, during this particular period of time, we are actively pursuing those kids who are not in person at school, who are at age of 12, who are missing their HPV vaccines and having them sent to us from the public health units so that we can make sure that we are administering these vaccines, because we know that during this particular period of time, there will be children who qualify for funded vaccines who will be missing their vaccines. So I would encourage you to do what we've done in our office, to look at those children age 12 and 13 and to see whether or not they have had their vaccines, and if not, to get them sent from the public health unit and administer them in your office. And of course, document vaccines received by your patients, not only the ones that you give, but the ones that they get elsewhere. So, vaccine hesitancy and health promotion. A patient may think it's a risk to take this vaccine. We think the risk of not taking the vaccine. So one of the most important strategies, as I've mentioned to you, that I often use is the notion of currency. So what is the currency of not taking the vaccine and then getting the disease that the vaccine would have prevented? That currency will be impacting health as one moves forward in life. The notion of science versus false ideas. The postmodern paradigm of healthcare, while power has shifted from not only doctors, but healthcare providers in general, to patients, and individuals turn to the internet for vaccination advice. Therefore, it is likely that the anti-vaccine website can influence whether people vaccinate themselves or their children. Science are facts and evidence, but often they're hard to communicate. So our challenge is to represent the science in a way that's easy to communicate. False ideas, well, those are very easy to communicate, particularly emotions and fear. And in the world of Twitterverse, we can often see in communities where Twitter endorses anti-vaccinating that we will see lower vaccination rates. We cannot underestimate the impact of negative content on the internet. A study stimulating a patient search on Google, for example, on MMR and autism, well, only 51% of the websites actually provide correct information. And the same is true for human papillomavirus. Individuals who refused or delayed vaccines were more likely to have looked for vaccine information on the internet. And a large-scale study published by Scullard et al. In Vaccine showed that surfing an anti-vaccination website for 5 to 10 minutes had a negative influence on risk perception regarding the decision to vaccinate one's child. Now, this is taken at one point in time, looking at Google searches and the number of results on vaccine topics. And you can see that the vast majority, aside from general vaccine sites, most of them are anti-vaccine websites. So if you just put in HPV and vaccine, this is what you're likely to see. Anti-vaccine owns a large part of social media, including the internet. What about sources of information for Canadian parents? So did you look anywhere or talk to anyone about vaccines? This is a research survey that was done, and about 67% said yes, in fact, they had. And if the answer was yes, where did you look? 2/3 looked at the internet. A little over half looked at physicians, and a smattering looked at other places. I had the privilege of sitting on the board of Research Canada, and over the period of time of a 7-year hiatus between our first and second interview questions to the Canadian public, asking them about where they got their information, we saw a rise in the internet and a much lower incidence of speaking to physicians or even magazines. The internet is extremely important, and what you find on the internet does not necessarily mean that it's true. So set enough time aside. Know the best communication means. And if you have a person who does like to search the web, then give them validated websites such as Immunize Canada, the Canadian Pediatric Society, the Public Health Agency of Canada, and Australian Government Myths and Realities. Australia, for those of us who endorse HPV, is really the hero country with the opportunity to eradicate HPV and cervical cancer in the near future because of their strong endorsement of the vaccine uptake in men and women both. The message. Well, often we know telling a story about a patient, a narrative, is way more meaningful than citing statistics. The greater the number of narratives that people read, the greater the perception of risk. And an emotional component that's based on fact is capable of getting attention and engaging minds in a way that leads to action. The basic meaning of the message is critical. Decisions are made on experience and memory. For scientists, the weight of the scientific evidence does not support the suggestion that the Hep B vaccine causes or worsens MS. Well, if you say that to a patient who's worried about vaccine and MS, it's pretty difficult to understand. But a simple phrase like little evidence that Hep B vaccine causes MS or no risk of MS from a Hep B vaccine for a Hep B hesitant patient who's worried about MS is critical. Just yesterday, I had a young man who's booked to get his vaccine who wanted me to reassure him that it would not affect his fertility. Now, in March of 2009, there was a scientific study that was published that still holds true today. And it asked all of us to have a plea for clear language on vaccine safety. That language of academia can be misleading. And this is almost, 2009, this is a long time ago, but we still have the same issues. Academics will state that a vaccine effect is unlikely. Public interprets that if they're saying unlikely, that means it's likely and there's causality. And instead of calming a fear, fears are fueled. Now, here was the conclusion from the Institute of Medicine's version on MMR vaccines and autism. And even for those of us who are in healthcare, reading it actually is not all that clear. And for someone who is a layperson reading it, it is quite concerning. The bottom line for the committee noting that its conclusion does not exclude the possibility that MMR vaccine contribute to ASD in a small number of children because of epidemiological evidence lacks the precision and on and on. Basically what that says to a patient is don't take the vaccine because you're going to have autism. However, a clear language version saying a thorough review of the research involving people and animals provides no evidence that the MMR vaccine causes autism. Because the causes of autism are known, research on autism needs to continue. Well, we have all these same types of concerns about HPV, so it's very important that we have clear, concise language to explain whatever the concern is, whether it's HPV and infertility or HPV and sexual promiscuity. None of these things are accurate, but they're often thoughts that patients might have. So know your audience, have your knowledge ready, know the answers to the common questions. Try and remove the emotional and knowledge barriers by knowing your parent, your child, your teen, your adult, knowing what to expect. And don't let them get under your skin, because this is not personal. This is in your role as a profession and a professional person to be able to communicate with your audience. Common myths and misinformations: no, vaccines are not pathogenic. And the road to vaccine licensure is not short or easy. And that even after a vaccine is available, and there have been millions and millions and millions of doses, we still have safety monitoring in place looking at vaccine adverse event reporting, vaccine safety data links. Science has debunked, for example, the thimerosal myth. We've debunked the aluminum myth. And no, there are not too many vaccines. And aren't we lucky that we have all these vaccines that science has provided with clear research and evidence and safety and efficacy to keep us healthy? Customize your recommendation. HPV vaccine is very important because it prevents cancer. I want your child to be protected from cancer, and that's why I'm recommending the first dose of HPV vaccine today. In my office, when I give that 5-year-old vaccine, I tell them that I likely will not be giving them, aside from the flu shot, a vaccine until they're 15. But when their child is 12 and they will be offered the HPV vaccine, that's the age in Ontario, it differs across the country. This is something that I want you to talk about and think about, because this is something that you need to say yes to. So if you read anything over the next several years that has you hesitating about giving the HPV vaccine, come talk to me, because I will explain to you why, when it's your turn to say yes, why you should be saying yes. I strongly believe in the importance of this cancer-preventing vaccine, and I have, and it's true in my world, given HPV vaccines to my son and my daughter. My grandchild's not old enough, but hopefully I'll be around to make sure that my grandchild does get the vaccine when it's his and her turn. Experts like the CDC, the World Health Organization, all agree that this vaccine is very important for your child. And research has shown that getting the vaccine does not make kids more likely to be sexually active or start having sex at a younger age. Hepatitis B has the same mode of transmission, and you wouldn't even have those thoughts about a hepatitis B vaccine. And human papillomavirus is so common that almost everyone will be infected at some point. Now, we know that individuals under the age of 30 with intact immune systems are likely to get rid of the virus itself, but not necessarily. So even if your son or daughter waits until a later time, including marriage, to have sexual activity, or only has one partner in the future, they still can be exposed, particularly if their partner has been exposed. And I think understanding what a social immunization initiative is very important. Having a position strategy to decrease barriers and highlight the benefits. Create content using evidence-based methods for effective communication, trusted local experts, narratives, simple numbers for risk perception. Tailored message is key. The gist theory, meaning that people will get the gist of the story, but maybe not get the entire part of the story and the science. Evaluate the strategy, tools for evaluating vaccine hesitancy within a target group, and the rates and the timeliness of immunizations. And of course, our policymakers. While they are not experts in the field of HPV and cervical cancer, we need clear, accurate, and up-to-date information on HPV cervical cancer screening, treatment, and HPV vaccines, and that's our job. The policymakers will decide as public health people when a vaccine is given as a public health strategy, but that does not mean if you're over the age of that public health strategy that it's saying that it's not important, particularly in women for cervical cancer. To know the burden of the disease, the vaccine effectiveness, coverage, and time to measurable disease reduction. A clear explanation of the rationale for HPV immunization, regardless of the age your patient is. So our call to action is to educate yourself about HPV and HPV vaccines, to recommend the vaccine with the same strength and conviction as you do other adolescent vaccines, to inform your coworkers so everyone has the same HPV message, to communicate vaccine benefits to parents and adolescents at every opportunity that we have, and to make vaccines procedures routine in your office and focus on ways to reduce those missed opportunities. And when it comes specifically to the HPV vaccine, the top 5 reasons for not vaccinating adolescents is lack of knowledge, the feeling that it's not needed or necessary, safety concerns, that it hasn't been recommended, or my child is not sexually active. These are areas that you can clearly make an impact in. Limited understanding of HPV-related diseases, especially in males, is very prevalent. Remember, when this vaccine first came out, it was a gender-based towards girls, until we recognized that, of course, disease goes back and forth. We never thought about giving hepatitis B only to males or only to girls. Vaccine safety concerns, or your own personal discomfort in talking about sexual behavior. The preference for vaccinating older adolescents undermines the importance of getting the vaccine in at around age 12 or 13, particularly when there is a school program. To anticipate parental resistance, which is why I bring it up well before the age of 12, or feeling that you don't have the time for a vaccine discussion when in fact it doesn't take all that much time at all. Or if you don't have a system to remind you to offer vaccines to age-appropriate patients. And I think that with EMRs, that's one of the best things that it does. An electronic medical record reminds us about what our patient has or not had, and shifting the discussion in terms of the one-time costs to the currency of what disease might look like. Limited understanding about extent of diseases and cancers, cervical, vulvar, vaginal, penile, oropharyngeal, and anal, is really important to be able to communicate that HPV has a very significant role in multiple sites of cancer. There still continues to be a low awareness about the risk of HPV. There may be confusion between HPV, HSV, HIV. There's a lot of H's in there. You got to be able to be clear about what we're talking about. And we know that our policymakers will have significant gaps in their own knowledge about HPV and the vaccine. In industrialized and developing worlds, there are different approaches in terms of data on HPV incidence and prevalence. We are lucky to know in North America what our circulating strains are and why our non-valent vaccine is so helpful. Developing countries will lack that epidemiological information on cervical cancer, and healthcare providers often feel uncomfortable discussing sexual issues. We live in North America, where in fact we have this data, and we can transmit this data and address parents' concerns about immunizing and recognizing that no, we are not immunizing with too many vaccines. If you look at physician drivers between the ages of 27 to 45, in terms of what will drive them getting the vaccine, often it's the history of abnormal Pap results or referral for colposcopy or history of an HPV infection. Down on our list is change in new relationship status, but for a woman, change in new relationship status is very important for her. And of course, we bias ourselves by age, recognizing that it's not just 27 to 45, there's no upper age limit. And of course, that becomes a bias for us. And then the cost of the vaccine is there. But look at the fact that in women 27 to 45, whether you're a healthcare professional or the woman yourself, cost is actually one of the last influencers to the barrier for discussion. And if we look at the barriers, often it's because we think a patient is in a monogamous relationship, or the patient may think the same, or the vaccine is too expensive, or the patient's not sexually active. None of these are reasons not to be talking about the vaccine. And from a patient perspective, their drivers, number one, my doctor strongly recommended it, or seeing information about it, or knowing that it's covered, or a friend or relative who endorses, or recognizing that they're at risk for HPV is very, very low for them. The barriers, thinking that I'm in a monogamous relationship and it doesn't matter. They don't recognize that any exposure they may have had before the monogamous relationship comes with them into that relationship. And HPV can be a latent disease that prevents later in life. I have a normal Pap. I practice safe sex, I'm too old for the vaccine, which we know is not true, or I am not at risk for HPV, which often is a barrier but is not true. So barriers to vaccination, well, we often think that it's the cost, but in fact, our patients tell us that no, it's the lack of physician recommendation. The number one reported barrier to vaccination for the general public was not having a recommendation from the doctor. Cost was seen as a barrier in only 18% of individuals in this study done and published in 2019. So the ASK approach. A stands for acknowledge the concern and clarify the concern. S stands for steer your conversation to refute the myth and continue your conversation. K stands for knowledge, knowing your facts well, providing information, provide benefits of vaccination, patient information, and of course, that very strong endorsement. So in summary, as healthcare professionals, we know that some of us are vaccine hesitant, and we know that if you are, that belief will influence whether your patient gets vaccinated. Patients need to hear the same message from all healthcare workers. Hearing another healthcare worker can be very negative and undermine the positive work of the patient's own healthcare professional's immunization recommendation. Making it easy to get the vaccine will be key. For patients, we have to understand what their barriers are. We have to utilize specific evidence-based strategy, communication that's effective, that's proactive, that's presumptive, meaning that we believe they'll get the vaccine, and listen, don't just have unidirectional provision of information. Don't dismiss a family or patient from the practice because they're hesitant or a vaccine refuser. Ongoing recommendation is the best strategy to get them to change their mind. Enforce the importance of community protection. Address the pain at immunization because fear of needles is often there for many people. Here are some additional resources that I'd like to end this talk with, looking at the Health Canada website. And here is the web link for you. And one of my all-time favorite websites, which is Immunize Canada website, www.immunize.ca, a very important website. And finally, encouraging patients to have the CANImmunize app is a secure way to store immunization records for they themselves. It's available on Apple and Android devices. It was created by the Ottawa Hospital mHealth Lab, and you can also find it by going to www.canimmunize.ca. And with that, I'll end our discussion on vaccine hesitancy and hope I leave you being a strong advocate and champion of immunization, and particularly HPV vaccines. Thank you for joining us today.
Thank you so much, Dr. Shapiro. This was really excellent. You gave us some wonderful strategies and a real overview to understand some of the multi-layered issues. I think we have about 5 minutes to open it up for questions. If in the participants, if you want to write in the chat box or just unmute yourself, please go ahead.
So there's one here about the language of being a champion, and that's going to be important in discussing COVID vaccines. You know, everybody is so now aware of the importance of vaccination, particularly COVID vaccines, that's a strategy that you can use to help you get uptake of any other vaccine, recognizing that here we have an epidemic of a disease, a pandemic, if you will, and that everybody wants to get the vaccine. Why? We want to prevent serious disease. We want to prevent death. And it's the same thing with HPV vaccine. In fact, there is an epidemic of HPV in terms of the likelihood of being exposed to that. We don't recognize it in the same way. But a patient who has HPV with advanced oropharyngeal cancer, we've had all of us HPV morbidity and even mortality in our practices. It's really important to bridge that in terms of the notion of being a strong pro-immunizer. And the next question I got was, how are you reaching out to all the 12 and 13-year-olds in your practice? So we are using Oscar, and it has the ability to do a web search. So we are searching all our patients in that age group, identifying them, and then through our ability to do a mass communication, we're emailing all the parents to say, Your child in grade 7 would normally be getting a series of vaccines, including hepatitis B, meningococcal meningitis, and HPV. Your child is entitled to these funded vaccines. If your child has not received these vaccines, please notify our office and we can order them from our local public health unit. We've had incredible uptake. And we've also advised our patients that if you're unaware, you can go onto your local public health website, put in your child's health card, their HIN, and it will give you what vaccines have been given in all schools. And that way you can tell whether or not they've had vaccine 1, because some of them have had the first vaccine, but are missing their second vaccine. And we've been enormously successful in getting free Gardasil. Usually they're sending Menactra to us and hepatitis B. And we've been vaccinating the kids in the office. It does take some work on my office staff, but public health is used to us calling now, and it's not an issue to get the vaccines at all. They send all 3 of the vaccines together. So we'll get in our first batch, we'll get the Menactra, Gardasil 9, and Hep B, usually it's Engerix that we're getting. And then as soon as they get that one, we put in a reminder at 4 months to order the next set, which will just be 2 vaccines, the Gardasil 9 and the Menactra, and then we administer it. So it can be done. And that's how we're doing it. So if you're not on an EMR, it's difficult to be able to find those patients, but on an EMR, all of them, regardless of what platform you are, you have the ability to search them by the cohort year. In my EMR, I can just put in age 11 to 13, or I can actually put in the date of birth, and they all pop up. So it's been great.
Yeah, no, that's great. We have the ability to search them. We just don't have the mass communication set up. So it would mean,
and even if you'll find probably that maybe you've got 20 or 30 of them, you probably won't have that much more. And if you can get one of your support staff to call them, I think it's really worth the conversation. We're lucky enough that we have this ability from our Oscar system to do a mass emailing, and it doesn't show anybody's email, so we don't have to worry about it. But you can do it through a Gmail function. You can add in the names into a BCC and send out that mass email to the parents as well. It takes a little bit of work, but if you're a pro-vaccinator, I think it's really a wonderful thing that you're a great service, because we know these kids are going to fall behind. We know they're going to miss their vaccines.
Just for the record, there's 34 different health units in Ontario, and not every health unit is doing it the same. In some of the smaller communities, certain public health units are calling the kids themselves. So it really depends where you are. You want to check with your parents to know what is the situation in your area. Bev, I know you're in Ottawa. They may be doing something slightly differently than in Toronto.
Yeah, yeah, I'll check. Thanks.
And you can even send out an email to your parents asking them to check. Check the vaccine status, reach out to your public health. We were told in some areas that the public health units themselves were doing catch-up vaccine clinics. So Vivian is right that you do want to check out what is happening in your specific area. But you can definitely at least open up the conversation to make parents aware that they're missing these vaccines.
Yeah, we did have a few vaccines sent from public health for some patients, so we're doing them. I'm just not sure who's looking after notifying them all. So This is good. I'll check into it.
Does anybody have any other questions?
And if any of you have the opportunity to do a vaccine hesitancy talk, please let me know. I'm happy to send you the talk. It took a while to put it together, and I would love it to get used somewhere else. So if any of you want the talk, you can pick and choose for other vaccine hesitancy talks, but it's sort of a review of the literature, and I'm happy to share it with anybody at all.
Thank you. That's extremely generous. And for those that are unaware, this does go on our website. We've recorded this session, and it will be available for at least 30 days. I want to thank you, Marla. It's just been a pleasure and really an excellent, clear, concise, and obviously evidence-based talk. We really appreciate it. I want to thank everybody for being on the call. I know that we are not getting the same numbers that we were expecting. A lot of people registered, but I'm sure have been just overwhelmed with office work and other medical work. And initially, I had planned on having a short meeting of the HPV committee after this talk. Given that the numbers are as small as they are, I'm not going to have that meeting. We will send out a doodle poll and plan a meeting for another time when we can get more people attending. So thank you so much, Michael from the Federation. Thank you for setting this up, for recording this. And it's a pleasure to, quote unquote, see everybody I see you, Shelley. I see you, Anjali. It's nice that you've been on, and best wishes to everybody. Have a good weekend.
Bye for now.